want to welcome you all to one of the Empower FNU virtual Nurse Practitioner Week events this year. This session is being co-sponsored by Sigma Theta Tau, the Chi Pi chapter here at Frontier Nursing University, in addition to the sponsors listed on the screen. I'm Dr. Charlotte Swint. I am an associate professor here at Frontier, and I have the pleasure of introducing my colleague and now friend, Dr. Susan Scott. Just a little bit about the history. Dr. Scott and I both attended the Creating Healthy Work Environments meeting earlier this year in Washington, D.C. And Dr. Scott presented on this topic. And after the meeting, we connected, and she said, if you ever would like for me to do a presentation at Frontier, please let me know. I believe that's how this story goes. Is that correct, Dr. Scott?
That's pretty close, yes.
Okay. So we took her up on her offer, and she is with us tonight very graciously. So without further ado, let me read her bio to you. Dr. Scott this is Dr. Susan Scott, and she has practiced the art and science of nursing in various clinical settings, including neonatal ICU, neonatal pediatric critical care transport, ambulatory pediatrics, risk management, and patient safety. She currently works as a nurse scientist at the University of Missouri Healthcare and serves as the adjunct associate professor of nursing at Sinclair School of Nursing. She has been a member of the Sigma Theta Tau Alpha chapter since 1984. Her clinical interest involves healthcare workforce well-being and the design of institutional support networks to address clinician support in the aftermath of emotionally challenging events. Sue's research has defined the second victim phenomenon, allowing for the design and deployment of the first of its kind peer support network for U-Team. She has published extensively in peer-reviewed journals on clinician trauma after emotionally challenging clinical events, and has guided healthcare organizations in the design of formal organizational support. Dr. Scott has partnered with agencies such as the Agency for Healthcare Research and Quality, the American Hospital Association, the Joint Commission, and the Institute for Healthcare Improvement to ensure comprehensive support interventions are accessible to healthcare workforce members worldwide. And today, Dr. Scott will be talking with us about the second victim experience, caring for our own. I would like to turn the presentation over to Dr. Scott.
Well, thank you, Dr. Schwint, and happy Nurse Practitioner Week to everyone who is a practicing nurse practitioner, and greetings from Alpha Iota chapter at Columbia, Missouri. It's an honor to be here tonight, and I'm so glad that so many folks have signed up to learn more about, a kind of a challenging event in our careers, and how that could have such a devastating impact on both our personal and professional lives. So just a few learning objectives to start us off. The next 45 minutes or so, we'll talk about the second victim phenomenon in our research that we've done at University of Missouri, how to recognize high-risk clinical events that could evoke a second victim response in either yourself or your colleagues or staff that work with you, and then describe what a comprehensive institutional approach would look like, offering holistic support using evidence-based practice, regardless of your title or role. So I'd like to just start us off with some insights from an individual who is suffering as a second victim. This was a nurse with a fair amount of experience who had a very emotionally devastating clinical event. And she just when the event happened, she felt very sick. She was shaky. She felt like she needed to throw up. She just wasn't exactly sure what was happening to herself, but she said she reminded herself of like she was walking into this very dark tunnel, and she didn't know what was happening to her. She kept walking, hoping that there would be a light that would kind of help her and she would start to feel better. What we've learned from this experience is that people walk through this dark tunnel, and when it happens, they don't know what's happening to them. they really, many of them feel like they might be even having a psychological crisis. They're not sure, they've never experienced it. And then the other thing we've learned is that individuals working with these folks understand that they're going through a stressful time, but they're not exactly sure what to say. So as a result, we tend not to say anything, which causes additional stress for that individual that's suffering. So today, what I'd like to do is put a light on that tunnel so that you understand more about the second victim experience through walking through this dark space after these uh, devastating clinical events that happen, and what we could do to help support if we're going through it, how we could help ourselves, or how we could help our coworkers. So I'd like to start out with a warning. I give my presentations a rating of E, E for emotional labor. Chances are good as we go through the discussion today that you might think of that one particular patient that went right through your coat of emotional armor and straight to your heart. And if that does happen, if I do rip off a scab of sorts, I just want you to put it in context to what we're talking about. And so hopefully this will help promote even more healing than you had before. The other thing I'd like to talk about is just a second about the whole concept of emotional labor, something we really don't learn about too much in nursing schools. But emotional labor is under the science of social sciences, and it's when the caring profession dictates the attitude and the kind of the expressions and our emotions of caregiving team members. And for decades and decades, healthcare has kind of told us just to kind of buck it up, keep it inside, and go to the lounge or just go home and where you can cry in private, and but never let the individual patient or your coworkers see you in distress. So the concept of emotional labor is really important as it applies to the work we're looking at today. The modern patient safety movement really started in the year 2000 when the Tuera's Human Report came out, 1999, 2000. And in that report, it was kind of disturbing findings. It said that between 45,000 and 98,000 individuals were dying each year in the United States as a result of um, preventable errors within our healthcare setting. So because of that, several things were set into motion. The modern patient safety movement started. The official role of a patient safety officer was designed. Patient safety organizations were formed so we could share lessons learned. So a lot has happened since this report came out. But one of the manuscripts that came out by Sir Cyril Chandler, he's a pediatrician in the United Kingdom, kind of summed it up perfectly when he said that medicine used to be simple and effective and relatively safe. Now it's complex, effective, and potentially dangerous. And I'd like to add to his quote, not dangerous not only for him, for the patient and their family members, but also for the well-intended staff who are caring for these individuals. So by the way, this is a picture of a 1 month old in an intensive care unit. So you could imagine just the sheer complexity, and with the young staff that we have right now, how intimidating this must be. And if anything would go wrong, the personal ownership that that young staff member might have. I was lucky enough to do a presentation with Dr. Albert Wu, the gentleman that coined the term second victim, also in the year 2000. And we were talking to a group of at the American Medical Association in New Orleans. And he went to the podium and he said, it's not a matter of if clinicians are going to experience trauma while providing care, but when and how often. And then he walked away from the podium and it was my turn. And I said, and how prepared are we to make sure that these emotionally traumatic events can be addressed in a very positive, supportive manner from our healthcare institutions? So I was fortunate to be one of the first patient safety officers at University of Missouri Healthcare, and that's how I really identified the problem. Um, I was a chronologically gifted nurse with lots of clinical experience, and I would work with individuals. It could be a physician, a pharmacist, a nurse. It could be a brand new graduate, or it could be the most senior attending physician we had on staff. And they would all say very similar visceral responses. And you can see them on the screen now. Probably the one that really got my attention was the one on the far right. This was one that a surgeon who I had worked with for decades and really truly admired his skills because I would see him repeatedly do miracles on my little micropreemies, and I had such a high respect for him. One day he was involved in a medical error in the operating room that caused pretty significant harm to a young patient. And I reached out as a new patient safety officer trying to figure out, what opportunities we had, if any, for improvement. And what I found at about it was we got to be at about the 36-hour mark post event. And he had done so much already. He had talked to the patient, to the patient's family, described exactly what's happened, offered to let turn care to someone else, or even transfer to another facility if that's what the family so desired. Um, he talked with the staff that were in the operating room that day. He talked with, he actually had a phone call in to the technology company, the equipment company, to talk to the design team to talk about maybe we could do a little modify the equipment so that it wouldn't impact the next patient or the next provider. He had just left lunch when we met, and he had met with a medical student who was very connected to this patient and who was totally devastated by what had transpired and was very disillusioned. And he kind of had her pegged for surgical residency applicant and was kind of pushing her in that direction. But he wanted to make sure she was okay. So he bought her lunch that day, took her to lunch just so she'd have an opportunity to talk. So we had a great conversation, and as expected, he had done everything that we could have done. At the very end, after about an hour and 20 minutes of a great conversation, I asked him, I said, how are you doing? This had to be hard for you too. And I really wasn't expecting his response. He looked at me, he gasped, and he started sobbing. So I reached into what I thought was a fairly sophisticated communication toolkit and realized it felt very empty. Here's a man at the pinnacle of his career, an expert clinician. Nobody would question his skill set. And here he is deduced to saying, I think I'm going to go to Walmart and be a greeter. I can't mess up somebody's life like that. And so in the moment, the prolonged silence, and I wasn't exactly sure how to respond to him. And so all I could think of was I said, I've worked with you for decades, literally decades. And I truly admire and respect your skills, and heaven forbid if myself or any of my family has to be on that operating room table tonight, I sure hope that I look up and I see you there. And so that helped him a little bit. So we've finished the conversation, and he left the office, and so I debriefed the chief quality officer, and I told him what had transpired. I said, I think the biggest lesson learned is I need to figure out a way to work with staff who are like experiencing this extreme response to these types of errors at our hands, and what we could do to be more supportive. Um, then the chief quality officer who I was reporting to turned his back to me, and he pulled out just a simple one-page front and back short editorial written by Albert Wu. He's works at Johns Hopkins as an internist, and he described watching a coworker, another or a resident, that had misinterpreted an EKG that led to the death of a patient. And it was in the same edition that he was talking, that we were introducing and having the first conversations about preventable deaths in the United States post the IOM report. And he said, there's more than the first victim, the patient, and the family members. There's also the well-intended clinician who was taking care of the patient and fell victim to a system error or a personal error that caused harm. And he referred to it as a second victim. So in the year 2000, the term second victim was actually coined by Dr. Wu. So I realized from that editorial, he said, this is what it's called, Sue. It's called a second victim. So, typical lifelong kind of learner experience, I turned to literature, and that was the only article that I could find on it. I could find a lot of literature at the time, late 90s, early 80s, that described stressors related to litigation associated with medical errors, but the whole population was just solely on the medical staff alone. I did manage to find one 1988 manuscript by a nurse who wanted to remain anonymous. And she wrote about the medical error that she had made that caused the death of a patient, and how that years later she still goes to work thinking that she's probably going to lose her job because of that error, and the many, many sleepless nights that she had. So she was actually pretty clearly describing what Dr. Wu was described as the second victim experience. I decided to go ahead and do a qualitative descriptive study where we would interview individuals who were recovered from their what I would consider a second victim experience and learn about that lived experience in more detail. So I wanted 30. I wanted 10 nurses, 10 physicians, 10 allied health professionals. And before we even started looking at any data, we realized the significant influence that this syndrome has on our healthcare workforce. So the first clue, I was partnering with our risk manager and I asked her if she could tell me the name of individuals within the last 18 months who she felt were recovered as second victims. It took her about 20 minutes and she had 118 names on her list. 118 names. Wow, that's a lot. Now, from the social science perspective that I was studying the group, I realized that I probably needed at least 120, if not 150, and they were probably encouraging more from the sample to recruit because such an emotionally sensitive topic, people aren't going to want to just talk to anybody about that, right? The first four people on the list, three nurses and a respiratory therapist, all were involved in one significant event at one of our community hospitals at the time. I reached out and soon realized that all three of the nurses had already left their roles, presumably because of this case. I reached out to the respiratory therapist and he too was gone. So now my first four out of 118 are missing in action. They're just gone. So I was really kind of worried. However, I just kept reaching out to people. We hit number 44 on our list and had our full panel of individuals who are willing to talk to us. Another remarkable finding. In fact, we did a conversation in the social science department on recruiting emotionally sensitive topics, and they wanted to know more about this. Why did people want to be involved? But these individuals, we actually ended up, I was on recruitment, I was recruiting number 28 when I had a phone call from an ICU nurse that I knew, and she had had dinner the night before with one of her coworkers. And I recognized the coworker's name as participant number 25. And she said, you know, Sue, for 14 months since we've been involved in this error, that we've been getting together about every 3 to 4 weeks and going out to dinner. And we've been trying to figure out how we could retool ourselves to jump off this healthcare ship. What can we do to be more effective? And she said last night, Sue, she has hope for healthcare. She decided she wants to stay and be a part of the support structure that could have helped us. She said, I would love to schedule a time that you could interview me. So I ended up with a self-recruit for an emotionally sensitive topic of where people really bore their souls about what that darkest hour of their clinical career was like. So these 31 individuals, after the individual conversations we had, we invited them back after we had analyzed the results and had some themes and some stages and some interesting findings. We wanted to validate our findings in the pharma member checking. So we invited them back to focus groups. And that was fascinating because these people all bonded and wanted to be together. And the first question we ask is, why did you participate in the study? And it was because of a sacred IRB protected zone that they felt like they could, for the first time, many times, share their personal story and how they felt and know that it was, considered protected information. It wouldn't hit the hospital grapevine the next day. So we got some incredible insights. One of the first insights we got was that we recognize that there's some high risk clinical scenarios that could evoke a second victim response. The first one that happens almost every single time is that somehow the individual patient connects the staff member to themselves. So it could be something like she spelled her name Catherine the same way my daughter spells her unique name, Catherine. We share the same birthday. Boy, they have the same, they look just like my dad and they share the same birthday. Probably the most demonstrative way I've seen this happen is one time we had an ER nurse who was a kind of ER nurse that could go from room to room and could take care of anything that walked through the door. Well, the ambulance radio blared that there was a 10-month-old in full arrest, probable SIDS, en route to our facility, something she had done dozens and dozens of times before. Um, and so she was in charge. She had it all set up. They brought the patient in. She was cutting off the pajama bottoms to start the interosseous infusion. And the little guy, the little 10-month-old, had a star-shaped birthmark that filled his entire left thigh. Now, I was a in pediatrics for many, many years, and I've seen round and I've seen oval. And sometimes to bend to parent requests, I could say, yeah, that's a heart-shaped birthmark. I don't know that I've ever seen one that was so prominent and so distinct, but this was a very distinct full birthmark. And so she kept going, and the paramedic or someone came in and said, the parents are here. And she said, what's the name? I want to talk to him. And the patient's name was Demarion, similar to her child's name. In fact, the same as her child's name. Her 7-year-old son had a birthmark, star-shaped birthmark that filled the whole left thigh, left his whole left thigh as well. She connected at a deep, deep level, and that patient really, really bothered her to the point of she wasn't sure she wanted to be an ER nurse anymore. So that's how you can connect. So if you think about a case that maybe is special to you, maybe that caused you some distress, kind of think, did I connect with that patient? Chances are really good. We had a rapid response team not too long ago in our main lobby, and the two nurses that responded, one knew the patient and the other shared the same date of birth. And so both of them were equally distressed, but in different ways because of that connection to the patient. Secondly, pediatric cases are really high at evoking second victim responses. Of course, anything related to a medical error, failure to rescue cases, especially when after the fact you can kind of go back and look and see that subtle decline in the patient. When everything clinically was going on, you really couldn't see it, and you can see it clear as day afterwards. And first death experiences are very haunting, especially for our newer grads, as young as they are, and what we could do to help maybe promote that. Recently, we've had some new additions to this list. In 2018, we started seeing a rapid increase in workplace violence events. About 1 in 5 of our supportive encounters were related to the emotional harm experienced by the clinicians after any type of verbal assault or physical assault. And thankfully, minimal physical harm was reported. And then with the pandemic exposures, we're also seeing that those are additionally high risk scenarios that could evoke a second victim response. I like to think about, so in patient safety, we've done a lot with our jet fighter pilots, aviation experts on safety, and they say, think of these as red flags. So one red flag in aviation, kind of get your guard up, think about, is everybody okay? 2 is it's a near incident on your hands. So if your personal story has 2 or 3 of these, then chances are good that you've got a hit. And so think about when you're working with your colleagues or with yourself, why maybe you're having these experiences post-care of these patients. The definition of a second victim has been evolving. It's a little bit different. My initial definition came out in 2007 based on our focus groups. And it was more focused on unexpected patient outcomes with a very high epicenter-centric focus on medical errors or adverse events. Since then, with the evolution of the team, the scope has increased. And so now we've expanded it to second victim as anybody working within an environment to provide care and become professionally, personally traumatized by exposure to a clinically challenging events. Note that this is a very holistic definition. It includes anyone within our care environment. That includes student learners, it includes volunteers, it includes plant engineers, environmental service workers, dietary individuals. Anybody working within our environment could be subject to experiencing a second victim response. We learned that second victims feel personally responsible for the outcome, regardless of if it makes sense or at all. Let me explain that. recently, or it's been a little while ago, we had a dietary worker who was responsible for delivering trays. She got really close to this patient and his wife. So one day she had 4 trays to deliver to that particular floor. She purposely decided to go to save that patient's tray for last so that she could get water or kind of give a little TLC to this couple that she'd formed a relationship with. When she walked in, the wife was asleep and the patient had passed, and she was the one that found the patient down. She really felt like she caused the death of that patient when we were talking to her afterwards, because she purposely decided that she would go last with him. What if she would have given that tray first? So it just kind of demonstrates the extreme amount of accountability that they have on themselves. They have a lot of self-blame, self-doubt, self-bashing is so prominent. And so these are just some tips that you might want to think about if you're working with a staff member in distress. They feel like they failed the patient. They feel like they've failed themselves. They feel like they've failed their unit, and they feel like they've failed their profession. They second guess their clinical skills and knowledge. You'll hear them say things like, any new grad would never have done anything this stupid. I'm pretty sure the first year nursing student would have picked up on that one, not me. And so whatever we could do to reinforce their skills is really, really important. They always feel like they could have or should have done more, and they just can't stop thinking about what else could I have done. This is a compilation of 18 studies of almost 12,000 healthcare providers. So it's everybody. It's primarily allied, licensed allied professionals and providers, and looking at the physical and psychosocial responses. And I think as you look at this list of symptoms, there's really no surprises. I mean, anybody in distress, you probably could anticipate this, but I think what's really remarkable is the high percentage of prevalence for each one of these. So if we know they're going to have anxiety, fear, embarrassment, how can we as healthcare institutions proactively address these events as they happen to maybe diminish this a little bit, to help support them and provide a nurturing, healing environment for them? We learned from our individuals, our 31 folks, that there's a very predictable recovery pattern that individuals go through as they heal from these experiences. And we're going to quickly go through these stages. I always tell people, don't memorize the stages, just know that they're going to be going through different things. It's almost like Kubler-Ross's stages of grief. They're going to be happy, they're going to be sad, they're going to be distressed, they're going to have just a wide variety of emotional responses. But just as a supporter, just be prepared for where they're at, what they need. The 6th stage is really an outcome stage. It's called moving on, and there's one of 3 potential paths of healing that the individual can take. They can thrive, survive, or they can drop out. And I just like to note that the moving on stage isn't really predictive of the clinician's ability to be successful in their chosen roles in the future. I think of it more as um, a, an outcomes measure for how well we provided a supportive, nurturing environment for that person. So it's more on the unit level or the hospital level and how well we did in supporting their recovery. So just a little bit. So the title of the stage is at the top. The quote right under the title is from the study, some one of the 31 individuals, some characteristics you might see. And I've just done an interesting phenomenological study with a nurse in Ottawa, Canada, and she was working on her doctoral degree. And she asked individuals who were involved in serious errors, medical errors, to find pictures of these different stages, either pictures, poems, artwork, music, something in the arts that could describe what they were going through at the time. So while these aren't the pictures that the students or the individuals in her study picked out, they're pretty similar to them. They're what I would pick out. So the pictures maybe might help you remember a little bit more about the stages. Stage 1, chaos and accident, happens the minute the individual realizes something under their watch has gone dramatically wrong. And it continues until care is turned over to another individual or a higher level of care. Could be very quick, as in like a rapid response team response to a general care floor and then moving the patient to a higher level of care, or it could be very prolonged, like in the case of some of our pre-hospital transfers. It take a little while to get the patients to another care provider. Um, they describe this stage as very chaotic thoughts, and you may have even come across somebody yourself early on as a first responder to an event, and they just kind of give you the bits and pieces of information. They don't seem to be associated. There's not a good history. It's not as it's very clunky kind of a report. That's because they're trying to process it in their mind what's transpired. They described that many times we had two of them describing doing CPR on the patient, and it was almost like an out of body experience. They knew they were doing compressions, but yet their mind was elsewhere. Their mind was thinking about, what do I need to do next? Why do I think caused this? What did I miss? And starting that kind of that downward spiral of self blame and self doubt. Once care of the patient is turned over to a different person, this is probably the most dangerous stage of recovery for the individual. This is when they self isolate and they try to piece together the story. This stage is where they plant seeds of self doubt. They start saying very negative, self bashing kinds of things. The self compassion is gone. In fact, the things that they say themselves, none of us on this call would ever say to a coworker or colleague, but it's just a very deep, hurtful thing. And if we can't interrupt, especially in this stage, those seeds of self doubt just kind of start flourishing. And all of a sudden, they feel like they're not worthy of being a healthcare clinician anymore. Third stage is called restoring personal integrity. And they talk about how unhealthy our hospital grapevines are these days, but they just know that everybody's talking bad about them. And are they going to be the dark cloud of the unit? Are they going to be the one that's the butt of jokes, and the one that maybe nobody wants to have on their pod that night? And so restoring personal integrity is so important to them. They really want to make sure that they're still a trusted member of the team, and they'll do whatever they can. And they look for signs that they're trusted. Sometimes it's just a matter of putting an arm around them and saying, I'm just glad that you were here for this code tonight. Or I'm just so glad I work with you. Anything assuring them is what they need. And they have that need on steroids, especially for medical errors, but also unexpected outcomes, workplace violence issues. Many times the individuals have to or respond to a variety of institutional investigations. This was one of the changes that our focus group made. We initially called it enduring the investigation. And one of the surgeons said, whenever you get that phone call, do you remember patient such and such, you're immediately on the hot seat. And so he said, I think we need to make it the Inquisition. It needs to be serious and purposeful. And so the name was changed to Enduring the Inquisition. But many times these people are so fearful of the unknown. And many of the times these individuals that are asking questions are individuals, they might not even know their names. They know their risk manager, their general counsel, or they could be a patient safety officer. They don't know who they are. And so even like walking down to their office alone, like remember the surgeon that came to my office? How dare I do that today? I would go to him, talk to him. I wouldn't expect anybody to come into an office suite and try to be interviewed. It just adds more insult to injury. Obtaining emotional first aid is really fascinating in that what we've learned is only about 15% of healthcare workers will ask for help on their own behalf. So think about that, 15%. And that includes what I would refer to as active weepers, those individuals that are just so distressed that you know right away that they are going to need your supportive presence. And they don't know how to do it. So they describe what you call hinting and hoping that maybe if Charlotte saw me today, she would realize that, boy, something's off with Sue. Or maybe Rosalie might say, hey, Sue, what's going on with you today? They hint and hope that somebody will just reach out to them and be a friend. And when you hear these people and hear the tone of their voice, they're desperate. One of the individuals said, I kept desperately looking for a lifeline, somebody on my team who still trusted me. Wow, that's pretty scary. That's pretty sad. Stage 6 is called moving on. And that's the healing that occurs after sometimes very prolonged periods of time. Sometimes it takes years to get over these cases. The path we try to encourage by offering supportive environment and peer support is known as thriving. This is a form of post-traumatic growth. And it's the individuals who take the experience, like my surgeon friend who had called the company and he actually helped them redesign this medical equipment so they would protect future patients. Although he was still suffering, he was trying to make a difference. He was trying to help the next patient. And so that's what thriving looks like. Surviving is when individuals have a baseline performance, the event occurs and they kind of plummet on their performance and they never quite get back to baseline. You might even hear people say they're not quite the same sense, and they could actually name the specific event. In social science, this is called presenteeism. When you're at work and you're not doing 100% because maybe you got a cold, or maybe you had a fight with your boyfriend on the way into work, or maybe your baby kept you up all night. We've all practiced presenteeism for periods of time, but these individuals might practice presenteeism for months, sometimes years, and they're never quite the same as they were pre-event. The ones that I really worry about are the dropouts. By definition, a dropout is somebody who, because of the clinical event, decide to change career paths. The first 4 people that we tried to recruit, the 3 nurses and the respiratory therapist, all are dropouts. Those are all failures on our part as a healthcare institution. They didn't have the supportive presence. Dropouts can be everything from an attending physician, surgeon going to bench research. It could be a pharmacist, compounding pharmacist going to pharmaceutical sales. It could be the best OR nurse you got going to teach scrub techs. But every one of them all talk about how they don't want to put their heart on the line again. They have to choose a role that's more protected so that they won't get hurt like they did with this first insult. We did a dropout study, and those are hard to find because once they're gone, they're gone. So we did a social media campaign, and we had about 500 individuals who responded to our survey. Interesting results. People willing to share their stories, many of them very sad stories that could have probably had just a little bit of a help, probably could have salvaged a very productive career. 3/4 of them are inpatient, not a surprise. I guess maybe an eye opener for me was that 25% were in the pre-hospital setting or in the ambulatory care setting. So as the nurse practitioners on the call, remember the connectivity? That could be connection of a prolonged period of time too, and getting to know the person and being part of that family unit in a way. About 1/4 of them were in the ambulatory or pre-hospital setting. Most of their events related to permanent harm or death of the patient. 50% were direct care providers, which was another interesting insight. The other 50% were either supervisors or educators responsible for a student learner, and a patient being involved in an event. So whenever we have one of these emotionally challenging events, it doesn't really just affect the person at the bedside. It has this ripple effect, just like if you throw a pebble in a pond. It has a ripple effect that could impact a lot of different people. 58% assumed a lower role. We ask IHI, the Institute for Healthcare Improvement, has joy and meaning questions. They have 5. So we asked those 5 questions. Their average score before their event was about a 4.7, meaning this job was so fulfilling and I had so much joy and meaning. 1 was indicative of as a paycheck. So the average score for the whole population went from 4.8 to 1.3. It was just a paycheck. So all of this just kind of helps promote the concept that institutions need to do what we can to avoid the dropout situation. Oh, I've got a picture here of Kim Hyatt. Kim, you might recognize the name. Kim was a pediatric nurse involved in a very not popular, very it was all over the media. Her medical error was all over the media. She was taking care of her primary baby, a little guy waiting for a cardiac transplant. Lots was going on that day. She was given a verbal order. I mean, it's perfect patient safety storm. Given a verbal order, gave electrolyte solution, thought something wasn't right, admitted to the supervisor, realized it was a tenfold error. The little guy died the next day. Cause of death, the leading cause of death was the cardiomyopathy with a strong contributing factor of a medical error. Kim lost her job. The State Board of Nursing, where she was working, actually had her on a review, performance review, where any medication, including Tylenol, would have to be observed, checked off by another nurse, even if the nurse just got her nursing license. It didn't really matter. Kim was a 24-year career nurse. She had trouble finding jobs. She left her role. She ended up serving as a carpenter's assistant, and one day decided that nursing was really her calling, her passion. She missed it and went home and committed suicide. So you might think that that's kind of rare as a dropout to have suicide, but maybe because of the work I do, I receive a lot of phone calls. And I heard about an ENT doctor that committed suicide just today. It happens a lot, especially when you're at the epicenter of a medical error. And what can we do as institutions? So just some data. This is 1,300 physicians at 6-month mark after they had a serious adverse event. 17%, almost 1 in 5, reported having significant negative impact on their private lives. Another study with almost 8,000 surgeons showed decreased quality of life, empathy scores, high burnout, high depression scores. That same population, within the past 3 months, they looked at 16% of those surgeons contemplated had suicidal ideation. So what we've learned is second victims really desire 5 things. They want to be appreciated, respected, valued, understood, but most of all, they want to be that trusted member of the team. So if you could just remember this, if you have a coworker in distress, kind of think about this. Now you might push back and say, Sue, really, if you look at this list, this is what every human wants. But I tell you that these individuals that are suffering in the aftermath of one of these emotionally challenging clinical events, these needs are on steroids. They need to hear it from the whole village. They need to hear it many times in different ways and in different forms, so that they can really appreciate and understand that they're getting what they need and desire. So this is a quote from one of our 31 individuals. What we did was we were wondering about supportive presence and how important it was. So we divided the group, those that got support, those that didn't get support. So I wanted the group to use their audience participation, use your imagination with this slide. There should be a ghost-like image that shows up on the back of this paramedic. All 31 talked about how this patient will stay with them probably for the duration of their careers. Only 5 out of the 31 had what they would consider a supportive, nurturing work environment. The other 26, so this was a very positive answer. She'll never forget it. Because of her, she's better. But the other 26 talked about it in very haunted ways. I'll never forget Valentine's Day at 2:00. It'll never be the same. Christmas Eve, I can't work on Christmas Eve because I'm afraid it's going to happen again. Those kinds of haunted things are really prominent in those that didn't get support. So we asked about 500 individuals, what should support look like if we want to do it? They wanted 2 types of intervention support. They wanted one-on-one by a peer. They wanted it to be, and then when the whole group is involved, they wanted a group. They want it to be voluntary. You can't mandate that they attend. They want it available at 2 in the morning if something happens at 2 in the morning, so 24/7 availability. They want peers. They don't want total strangers offering support. They want somebody that's walked the walk of a nurse in the ICU. They want to be able to relate to them. They want it to be confidential. And they also said, we need to be able to tie together all of our institutional resources so we could fast track referral to expert mental health providers if that's needed. So this is a 3-tier model of support that we've implemented at University of Missouri. Many, many hospitals have emulated this. First tier is local level. Local departments, they can take care of about 60% of our care team members. Tier 2 is where we have our trained peers as well as our group debriefings. Tier 3, where about 13% of the individuals have needs exceeding capabilities of trained peers, need the professional expertise of a mental health provider. So does it make a difference if we provide a supportive work environment? So this is a group that I am honored to be able to work with. It's called Batera. It's a healthcare company that does different kinds of surveys for hospitals. They do a hospital survey on patient safety culture, and they've added a few questions so that the participants only need to do one survey a year as opposed to two or three. So these are results from 2018 to 2020, so really truly before the pandemic, but it represents 118 facilities and almost 74,000 providers or allied healthcare or responders, and about 4,200 providers or advanced practice nurses. So they ask three questions. They look at second victim prevalence and perceived support. They look at the staff perceptions on patient safety. And the 5 joy and meaning work questions that IHI, the Institute for Healthcare Improvement, have, they look at those as well. So by asking the first question, within the past year, did a patient safety event cause you to experience anxiety, depression, or wondering if you're able to continue to do your job? If they say yes, then that's a self-described second victim. They would get a follow-up question if they said yes. Did you receive support? So what that does is it gives us 3 unique populations that we can analyze differences in these responses to see, does the perception of support make a difference for our staff? So the first question, within the past year, so on the left, within the past year, did a patient safety event cause you distress? 14% said yes. So 1 in 6 of this population said yes. And 50% got support. That's pretty awesome. Our sweet spot we've found with a previous study from Duke shows about 60% is what we need to aim for. With COVID, what we're seeing is these national averages are dropping. They're more like in the 20s now, 30s now. People are really craving support, and the prevalence is so high, it's hard to keep up. This is the composite of the culture survey scores. So the x-axis are the 10 dimensions that are measured in the culture survey. There's about 2 or 3 questions that roll up into each one of them. And it's a 1 to 5 Likert scale, but if you agree or strongly agree, then the score could be up to 100%. And so if you look at the bar graph, this is just the dark blue are the non-second victims, and the lighter blue are the individuals that identify themselves as second victims. Every single 10 domains, they significantly scored different. It might be a little bit easier to look at it in this manner. So on the grid, we have the far columns are non-second victims, second victims with support, and second victims without support. So I'd like for you to focus on second victims without support. So I worked with biostatisticians at ARC and asked them, if a unit makes a difference and does an intervention to address a patient safety score, what would be considered clinically meaningful? So they told me a 0.3. If you have a 0.3 or more, something positive has happened or something very negative has happened, depending on the direction it goes. So if you look at these, every single one of these are clinically different from the non-second victim counterparts. Every single one of them. And if you want to go into p-values, all of these are statistically significant at p less than 0.001. So these are like thousands of individuals that are showing us there's this huge difference between perceived support. This is maybe another way to look at it, but the second victims, so the darker blue on the top is always the non-second victims. They're always consistently, no matter what facility you look at, whatever role you look at, whatever title, whatever unit, they all are the same. It's almost like it's a mirror image. It's uncanny. Non-second victims always score higher, but the second victims with support are very, very close. They're not statistically different at all. They're not clinically relevant difference at all. But if you look at the lighter teal color, the bottom, I call them the bottom dwellers, that's the individuals without support. And that's how different their scores are. This is the IHI joy and work questions. I'm not going to go through the 5 questions in the interest of your time, but once again, the dark blue is the non-second victims. Underneath of them are the supported individuals. And those that find less joy and less meaning in work are those individuals that weren't supported. Those are the individuals that are either actively thinking about dropping out or that are practicing the presenteeism. So that's the survivors or the dropouts. So what that does is, and here we have to have some audience participation again. I'd like for you to use your imagination. Should be a downward spiral is what I'm trying to showcase. When you have one individual on your team who's suffering as a second victim, who perceives that he or she has not gotten support, that traumatized clinician actually self-isolates from the group. And what that isolation does is it kind of snowballs to limited communication, kind of eroded a little bit of the teamwork. The morale starts to shift a little bit. And those units that have a high prevalence of second victims without support have incredibly low scores on all of these metrics: net promoter scores, healthcare well-being scores, joy and meaning scores. All of them are a lot lower. And a lot of it can be contributed to specifically the population of individuals without the perception of support from their environment. I'd like to, before I close, just talk a little bit about the name second victim. It's a controversial name. The international researchers, we just got together this afternoon, we're trying to think of an alternative name, but Dr. Schwent assures me that there's a lot of brilliance on the call today. So if anybody has an alternative name, please let me know. My very first manuscript, I wrote wounded healer because I didn't want to label somebody as a second victim and label and cause additional harm. However, in my member checking and focus groups, I ask, what do you prefer, the term wounded healer or the term second victim? And I had a very outspoken surgeon tell me, don't sugarcoat this, it hurts. Second victim it is. So ever since then, I've used the term second victim. But our military colleagues frequently will call it collateral damage. Our mental health professionals will call it vicarious trauma or secondary traumatization. I've had a couple hospitals that actually have been so negative on using the term second victim, they've identified alternative terms as silent sufferer and the forgotten victim. But none of these actually fit. I have a feeling it's going to be an acronym of some sort, but until then, what we want people to do is focus on the supportive presence of our environment and not so much on what the name of it is. So before I end, I just like to give you some tips on what if you are a second victim? What is some self-care you can do? So right now, proactively develop a perk file and periodically kind of reflect. If you're having kind of a down day, reflect on happier clinical experiences. They're there. But sometimes when you've had a bad day, like a second victim kind of day, you haven't done anything right. So you need to have this self-help a little bit. Proactively think and do an exercise right now. Who would be a trusted colleague that I could reach out to and befriend if I don't have one in my immediate work environment that could help me heal, help me grow in a very positive way from this experience? Rely on what you've done in the past for successful stress reduction efforts. These folks that are suffering don't feel like they deserve self-care. I had a jogger who jogged all the time. I saw her all over town. And one night, when she was upset, I asked her, was she able to kind of stop thinking about the case as she jogged last night? She goes, I didn't deserve to jog. I didn't deserve to jog last night because I was so bad at work. She wasn't bad at work. That was her in her mind. I said, tonight, will you do me a favor? Will you go run and try to think about nature and what's around you? And if you start thinking about this case, purposely divert your mind to what's your surroundings. Okay, I'll run for you tonight. Well, obviously, I could use it. You can't see a full body, but I could use some jogging. But they don't feel like they can use it. So, whatever you do to help promote stress, know that you need to be doing that. Reflect on your patient outcomes, and foremost, know you're not alone. Whenever you get one of these experiences, you feel very unique. You feel like nobody else has ever been there. But as a human and answering this calling that we've all had to come into healthcare, we all realize how important that is. What can you do different? And chances are several of you are thinking about a coworker right now that maybe had a really rough day today or yesterday. Determine a way that you can make a difference for that person. Reach out. Don't make them hint and hope for a lifeline. Be that lifeline for them. Be the person that you needed. Just you being there is really what they need. So I'd like to close with, if in doubt, please reach out. I'd rather have 10 false alarms than have somebody go home and try to process some of these feelings on their own. I've included in my contact information. The website includes information about our For You team. We just celebrated our 15-year anniversary, and so we're kind of proud of it, and we've got a lot of information out there to share with the world. So with that, Dr. Schwinn, I'll open it up if there's any questions.
Thank you so much, Dr. Scott, for that very impactful presentation. I think that all of us have had colleagues or personal experiences that we can relate back to the things that you've shared with us tonight. We don't have any questions in the chat box. We do have the reminder with the link that you can click on to receive credit for attending this session, CE credit. There is a post test, so please complete that link. But does anyone have any questions they'd like to ask Dr. Scott? You can unmute and ask questions now.
Hi, this is Charlotte Morris. I wanted to just thank you so much for this presentation. You said some things that put it in a different perspective, but myself and one of our colleagues, we wrote an article that was published in 2020 on second victim phenomenon, with the emphasis of looking at how midwives are impacted. And interesting enough, we could not find any research here in the United States. So most of our references related to midwives were from Europe.
Sweden, probably.
Yep, and Australia. So really good. So the one thing that you said different, which I had to think about a little bit, was that it's not just the provider, that it's everyone that has been caring for that patient or who has had a relationship. And so one of the things that came out of our research with the midwives, which I kind of relate to that comment, is even if you didn't physically, if you had to transfer care and you didn't actually do the delivery and there still was a bad outcome, you were just as impacted as if you had done the birth and it was your fault. So that kind of related to what you said. The others around who have cared for that person or done something with that person will feel the same thing. So thank you so much. I didn't really have a question. I just wanted to share.
Charlotte, I haven't read your manuscript, but you said it was 2020. I'll have to look it up.
Yeah, yeah. And You Matter, where you're at, was one of our references.
Okay, yes.
I'm very familiar with Dr. Wu and John Hopkins. And what I thought you were going to tell the story about the baby that died that caused them to start their program, the RISE program at John Hopkins. But thank you so much.
The little king baby. Yeah.
Yes.
Any other questions?
Yeah, I have a question.
Hi.
Hey, my name is Tony. My background was mostly psych nursing, but I went to a different type of floor. So about 2 weeks ago, I had a patient spit on me, and when it happened, it just kind of took me by surprise because it's not a psych unit. But anyway, so I go to management, and we type up the documentation, and they were like, oh, we don't tolerate place violence here, blah blah blah. And they had me talk to a psychologist because I come from psych, and I've actually got attacked in psych. And I told them, I said, I would rather be attacked and physically beat up, which has happened to me, versus somebody spit on me and they did it out of spite. So anyway, my question is, I went to work the other day, and another nurse was saying that I feel like they were blaming me because he did it because he couldn't get into the chair as quickly as he wanted to. I felt like they were kind of talking behind my back and kind of blaming me for it, because it was like when it happened, they wanted to call somebody right then and there to train me on how to do lifts. And that's why I got spit on. So I felt like it was kind of like a blame game. So I guess
Mhm.
my question to you is, how do you deal with, I don't know if it was being fake, but how do you deal with, oh yeah, we support you, but then yet I hear from another nurse who's a trainer, they were saying smart things behind my back. Like I feel like I lost trust in
Mhm.
reporting stuff. So I just wonder, how do you deal
Yep.
with that?
And keep in mind that one of the deepest things that individuals want is to remain being a trusted member of the team and not being the topic of your hospital grapevine the next day. So that a lot of that has to do with your local culture, and what's tolerated. And so perhaps the leader on that group um, has a role too to support you, Tony, and to help you heal. And so he or she should be actively involved in understanding your feelings and how you feel like you're being talked about. Also, maybe keep in mind, Tony, that sometimes when you're when you feel like everybody's talking about you, and in reality, it's not exactly the case. But everything is kind of blown up in your mind when you're suffering after one of these types of events. So what you're going through is perfectly normal. I would say that vicious grapevine gossip probably shouldn't be tolerated, but sadly, that's part of a lot of healthcare environments these days.
Thank you. And that makes me feel a lot better. One more other quick question. So I don't really have a huge support system, other than maybe like one friend who's not, healthcare. Other than EAP, do you have any other resources that maybe you can refer people, or just how to connect with somebody who maybe understands a medical setting? Because my parents don't want me here, complain about a patient dying,
Sure,
or
sure.
like I've struggled with resources at this point too as well.
So one thing you could do, Tony, if you want to write to me, I can give you some national resources that we have that maybe that you could read about some more. Sadly, I just learned today that Betsy Lehman Center in Boston is offering peer support. So talking to people like yourself, but you have to live in the state of Massachusetts. So I'm hoping maybe that with the spotlight that COVID has put on clinician well-being, that maybe we could look at figuring out a way to have like a hotline that people could call and just talk through their events in a de-identified manner. But right now we don't really have um, that in place. But if you send me, my email is on the screen right now. If you send me an email, I can send you a couple written resources and maybe we can even touch base.
Thank you. Appreciate it.
hmm If you disconnect and you think, oh, I wish I would have, feel free to send me an email. I love to hear from folks and get feedback. I guess, Dr. Schwint, there's going to be an evaluation process to be able to get the CEUs for today's presentation.
Yes, that's right. An email will be sent to everyone who registered to attend, and there is the link in the chat box. The other thing that I'd like to mention, if you do email Dr. Scott from your Frontier email, when she emailed me back the first time, it went into my spam folder. So if you email her and think that she hasn't responded, look in your spam folder, because I emailed her again saying, hey, we are trying to connect. And she's like, well, I replied. So somehow Frontier has a good spam blocker. So, but again, we appreciate you so much being here with us tonight.
Well, I'd like to thank everyone for their time tonight. Thank you for your interest in the topic and know that you can make a personal difference. So please reach out.